So I'm April Harding from the World Bank, and if you've been on the email exchange, the very long email exchange about this paper, you would know that I have been trying to get something organized where we could have a discussion on this paper. I think since I read it, which was, I think, really the week it came out, so it's been a while, but clearly it's a topic that is of interest to lots of people. The topic is, what is health system strengthening and how does that differ from health system support? And the reason that I think it resonated with me so much is that it seemed to me that this was the distinction was something that underlied a lot of the sort of issues that I was struggling with in my own work at the World Bank. And yet I sort of felt like there weren't that many conversations going on about it. We were talking about a lot of things, but we weren't talking about the sort of the underlying things. And if anything, intuitively, I felt that we might be shifting more in the sort of world of global health development assistance towards health system support, but not by conscious decision, just because a lot of other things were going on, and it sort of seemed to be taking us in that direction. And it was something that seemed to me to really merit at least a conscious discussion and decision before you'd want to move in any direction. And then just on a sort of maybe a slightly related note in terms of not being able to define what is health system strengthening very clearly, an exchange that we had in the World Bank not that long ago was, well, we wanted to recruit more health systems experts, health system strengthening experts, really. And then I don't remember who it was that had sort of written down what the training was that we would be looking for. I think it was just a rough draft of sort of like a recruitment announcement. It was really focusing on economics. And I looked at that and I thought, well, that ain't right. I mean, I'm an economist, so I'm allowed to say that. And then I sort of, I said, well, let me go look and see what else we might do. And so I called like 5 people that I really thought like were the best health systems experts that I know, the people that I would want to come and help me if I were the Minister of Health and had a broken health system and I wanted to fix it. These were the 5 people that I would call, and no 2 had the same training. One had some economics training, but the others had, like public policy, public administration, sociology, business, finance. I can't even remember all the things. I think I did. Oh, I think anthropology even. So, underlying, it's like it's a many-layered problem. Like if we can't define what it is, we can't define what it means to have that kind of expertise. Like what would be good advice? It's a deep problem, and it's, at least I would argue, very relevant for what all these agencies do, and probably what many of us do in our daily life. So, yay, we get to talk about it! Yay! So I'm going to introduce Grace is going to be the main speaker. Grace Chi, has a name up there. And also I've been polling people on their training. So I asked Grace Chi, she's with Apt Associates and has been working on health systems for under USAID projects for 20 years. But before that, her training was finance from Wharton. So just strengthening my data set that confirms, it takes all knowledge to work in this area. And then Joe Namoli, who I met when he was seconded to the World Bank from the CDC. Now he's seconded to USAID's Office of Health Systems. Nothing after that. Health systems, I said, is it health system strengthening? Health system support? No, it's just health systems. So that's where he is now. We met when he was at the World Bank 5, 6 years ago? 7, 8?
7 or 8.
Yeah, we should stop doing the math, right?
Yeah.
And then another, Catherine Connor is here, and she's also one of the authors of this excellent paper, and Nancy Helmer is here. And I never met Anne Ryan.
Anne is out of town, yeah.
Okay, so we only get 3 of the 4. So definitely you've heard enough from, oh no, Joe's training was, he has something I've literally never heard of, a Doctor of Science of Public Health. A Doctor of Science of Public Health, plus a Master's in Public Health, plus a Master's of something else. What was the other thing?
Romance language.
I don't want to. Okay. Romance languages. Excellent. All right then. So clearly it takes all types to do health system strengthening and to also to have a panel on health system strengthening. And we have all the bases covered. So thanks for coming. Now I'll turn it over to Grace.
Thank you. Thank you for pushing to have this finally come to fruition.
As you know, I'm going to be presenting a paper that we wrote, Nancy, Catherine, and Ann and I, about 3 years ago now. And I wanted to, before I start, I wanted to give a little bit of sort of the historical context of the time, because the language and the priorities in development changed so much in 4 or 5 years. So at that time, in the 2010-2011 time when we conceived of this, there was broad recognition in the global health community that a lot of these interventions that are implemented in vertical silos were not going to be sustainable. And this really grew out of some of the global health initiatives, the Global Fund and Gavi Alliance. And that led to a lot of donor investments in the health system. Both the Global Fund and the Gavi Alliance started a window of funding for health system strengthening. And even PEPFAR 2 incorporated in its refunding a goal for health system strengthening. But why did we write this paper? So at that time, there was so much interest in this topic, and people were doing so many things in health system strengthening. But to us, it went from distributing contraceptives to training health workers to putting in new labs in a country. How were these things to be compared? How would they strengthen the system? What would be the long-term impact? So we thought it would be good to clarify the language around health system strengthening. And basically our paper offers up a distinction between health system support and health system strengthening. So what is the current situation? I think now there is a lot of recognition that the priorities, the language today that's important, country ownership and sustainability, they're really grounded in strong health systems. As April mentioned, USAID established the Office of Health Systems several years ago. I think in the last year we've been hearing about health systems because there's broad agreement that weak health systems can contribute to global health crises, as we've seen with the Ebola epidemic. And that, I think, is interesting because that was not just a conversation within the global health community. It was on NPR. It was in the New York Times. And I think as over the last several years, the approach to health system strengthening has continued to evolve. So these are just sort of some random collection of papers on health system strengthening, guidance, interest. As we all see, everybody's business, that was sort of the seminal work that put health systems, on the agenda, with the WHO framework. One thing I think is interesting, this doesn't, wait, it does it. Anyway, this Global Fund piece was the first, approach to health system strengthening in March 2008. That was a 3-page piece. The most recent guidance issued last year is now like 40 pages because people realize it needs a little more explanation than that. But I think even with all of this interest and guidance and all the papers that are written, there isn't truly common understanding of what health system strengthening is. So in the first round of the Global Fund, the technical review panel found, and this is quoted, the definition of health system strengthening was too vague and too broad. Under the new funding model and the new guidance, the Global Fund says health system strengthening has to be cross-cutting across the 3 diseases. So previously, you could just strengthen the health system for HIV/AIDS. And also, but at the same time, they're encouraging countries to prioritize procurement and supply chain and HIS. The same thing has happened within Gavi. They commissioned an evaluation, I think that was in 2009, that found that the health system strengthening funding within Gavi countries have focused on immediate support to deliver immunization and MCH services. Another study a year or 2 later also found that Gavi countries focused on short-term operational responses. And even more recently, in unpublished work, just in sort of informal conversations with work that's been funded by various donors of Gavi HSS, we see that there's a continual focus on countries, by countries, on short-term operational responses. So what is health system strengthening? I think the most complete definition still comes from WHO and seems to sort of touch on all of the pieces we're interested in. And it says health system strengthening is improving the 6 health system building blocks and managing their interactions in ways that achieve more equitable and sustained improvement across health services and health outcomes. But I think perhaps the confusion comes in people just sort of stopping at the first 6 words, which says improving the 6 health system building blocks. And I think that has become the most common understanding of HSS. Any intervention working in any building block. And HSS sort of for a while, and I think it's evolving a little bit, has become just synonymous with the building blocks. any building block is health system strengthening. And I think there are some key words in the definition that if we just paid attention to a little bit more, we can sort of get at the crux of what we're trying to do, which is managing the interactions between the building blocks, aiming toward more equitable and sustained improvements, and then working across health services. So why do we think there's this confusion? We think there are many perspectives to the health system. There are people who dedicate their whole careers to working in immunization programs, and all that's very necessary, but their goal is to focus on ensuring all of the inputs needed to deliver immunization with 100% coverage is there. So, that's the perspective they're coming to the health system with. There are people who work their whole careers in HIS. And although that's cost-cutting and it helps support, all the different programs, it also fragments the health system in a different way. And then lastly, there are what I call the traditional health system reformers that have described a set of control knobs, and this goes back probably 15 or 20 years, that a set of policies that can control the system, and they include, financing policy, payment mechanisms, how the organization of the health system, regulations, and I think these are all just quite different perspectives that influence how we approach what the health system is and how we strengthen it. And then also they're also contributing to this, sort of very different interpretations of there are different priorities for the health system. So there are certainly people who think reaching the poorest is the most important, and others who are looking to make more efficient use of the funds that we have. And also something that we've reacted to is the emergency response to disease control. So certainly in a real emergency, we're not saying you need to fix the road before you bring in the drugs. You parachute them in and you fly in the doctors. But at some point you need to move to a more systematic way of doing things. So in response to that, in this paper we offered up a graphic which we hope can help illustrate the difference between support and strengthening. Now my kids thought this was totally incomprehensible. So let me start with that. Luckily we're all adults.
Yep,
so
we won't say it.
Yeah, exactly.
I just think it.
Yeah.
So the health system includes health programs. So we have a TB program, we have an HIV/AIDS program, we have an immunization program, and many, many others that help improve health. Each of these health programs needs to have these functioning building blocks. The TB program needs to have the HIV/AIDS program, the immunization program, they all need to have the physical infrastructure to deliver services. So for TB, that may be health clinics and hospitals. For the EPI program, it may be motorbikes that get people out to where the kids are. They're different from one program to another, but they need to have the physical infrastructure, they need to have the trained staff, they need to put in place the reporting and information systems. They need to be able to get the drugs, not just buy the drugs, but get them out to where they need to be when it's needed. And underpinning all that is the funding and the management and leadership that's needed to help keep these programs going. But I think what I just described, we would call the inputs to the health system. They're all critical and they are absolutely necessary to make the health system function. But by adding these inputs, we're saying we're not quite strengthening the system. We think in order to strengthen the system, we need to have this depth, and this is why we came up with this Q. We need to work on the policies and regulations, the organizational structures, and put in place incentives that modify individual behaviors in order to strengthen the health system. So what might that actually mean? So let's say in the example of the health workforce, we can train staff, but instead of only training staff, we need to put in place ways to review their performance and then tie their salary increases, tie incentives to performance and to outputs. Make sure there's a way to accredit and ensure that they're of high quality. Those to us are what's more of a health system strengthening intervention versus just health system support. So just to put it sort of in more language, we'd say supporting the system can include any activity that improves health services. You might renovate facilities, you could distribute mosquito nets, you can train workers to do community case detection. All that improves the functionality of the system by providing inputs, and the results tend to be narrowly focused and more short-term. Strengthening the system requires a more comprehensive set of changes to policies and regulations, organizational structures, and relationships across the health system building blocks. And the goal there is to motivate changes in behavior that allow more effective use of resources in order to improve multiple health services and to have more lasting impact. So I want to use an analogy of human health and a patient. So imagine, a patient comes in, he doesn't feel good, his diagnosis is he's overweight and he has high blood pressure. Well, what's an immediate input? Some medication to manage the blood pressure. We don't want the guy to have a heart attack tomorrow, and that's the most immediate response to it. But strengthening his health requires a longer-term change that he needs to be committed to, and they may involve changing his diet, losing weight, exercising. And I think one critical thing that I really like this analogy in terms of human health and a health system is it requires patient commitment. You can't just drop in fridges and drugs. The country and the people in the country need to really be engaged and take active part in strengthening the system. So here we would say, both a combination of short-term treatment and system improvement is needed, and that the outcomes are better health. So why do we need the distinction? And this sort of is related to why we wrote the paper, is we think some activities that are currently funded as health system strengthening or as HSS could be better described as support. And that because of that, there may be expectations that they create long-term systemic changes, and those expectations will not be met. And as a result, we would hate to see health system strengthening discredited for failing to produce long-term outcomes. And then lastly, because there's a lot of funding, if most of it is going into support, are we ignoring true health system strengthening needs that are in these countries that we work in? So here's the question, that sometimes comes up: what should we be doing? And we would never argue only one or the other, both. We need to do both. They're both necessary, they're important, but the balance depends on the country context. And I think also the point of our paper is let's at least recognize the difference and understand that they lead to different outcomes. So why do we tend towards support? I would say it's easier in so many ways. Imagine the problem. You don't have enough health workers. They may be unmotivated. They may not turn up to work. Some of them are not as well trained as they need to be, and there's very high turnover. What are some of the solutions? And we've all done this in our projects. Don't anyone pretend not to have. You do some in-service training. You may provide some top-ups, salary top-ups that motivates them for some period of time to produce the outcomes your project needs to produce. So what are strengthening solutions? Well, we might think about, are they coming out of school with the training that they need? Do we need to address pre-service training? And what do we need to do that? Well, that's a hard question, and everyone will say, well, that's under the Ministry of Education. That's not our responsibility. We may need to put in place, incentives, and salary increases that are tied to real performance review. And everyone will say that's under the Civil Servants Ministry, and that's not our responsibility. So these are much more challenging issues to address. But I think also, from the donor side, what makes strengthening so hard is, we're all working in these 2, at most 5-year funding horizons, and these are all relatively higher risk activities. You could walk over to the Ministry of Education and they don't want to talk to you. And where do you go from there if you put that in your project work plan? So I think I have a minute just to say a few words about health systems and Ebola. Because I think that has generated a lot of interest very recently. And I think the point here is Ebola took place in countries with very, very weak health systems. There were severe health worker shortages, extremely resource scarce environments. And scarcity, I think everyone has to recognize, was a critical factor in the response. So we would never argue that it's because the health worker didn't have a performance review system in place is why it was so difficult. It would, these were just very, very poor countries, and there are many, many immediate input needs that need to be addressed. But I think the question that we would like to ask is, how can we take advantage of the emergency response and all the money that's going into these countries? I think yesterday an article came up that there were $650 million going into these 3 countries to strengthen the health system. How can we take advantage of that, of what's being done, maybe related to Ebola, to strengthen surveillance and reporting systems, to integrate the facilities that have been built to treat Ebola? How can we, although, there are immediate input needs, how can we at the same time take advantage of that to strengthen the system? And then my last slide, which I think hopefully will be a nice segue for Joe, is to talk maybe just a little bit, and I'm afraid now that I see someone from AID in the room, about a little bit about 2 people.
We were
you're just a conduit. To mention, the draft vision for action for HSS, which has been circulated by AID, to say that, from our perspective, maybe that demonstrates a bit of a shift or transition toward what we would like to think of as health system strengthening. And they pose a definition of HSS as the strategies, interventions, activities that are designed to sustainably improve the health system performance. And I think another sort of point which is in this draft document, which I also like, is that it recognizes the complexity. There's not just a set menu, there aren't just these 10 activities, and one of the quotes from this document is we can have the greatest impact by customizing USAID HSS support to the country context. So I think I'll stop with that and pass it on to Joe.
Excellent.
Pull this over here, 'cause I do not have a presentation as such. I don't have a presentation, but I have some remarks that I'd like to share with you that relate to Grace's presentation. First of all, I want to thank the organizers of this session for inviting me to participate. So thanks to April and to Grace and to all of her colleagues who were co-authors on the paper. And I thank Grace and her co-authors for a very provocative and interesting paper. I've read it multiple times because I find it really useful and very handy in the environment in which I work. First, though, I want to begin with a clarification about the task that was assigned to me, which was to give a donor perspective on the paper. I just want to say that during the last 4 years, I've had an opportunity to engage many people at USAID in both formal and informal conversations about health systems. First, by virtue of an internal health systems management review that I facilitated, and actually Estelle Quains here from USAID, she was also helping me with that review. Also, I was involved with helping to compose the Global Health Initiative principal papers on health system strengthening and integration. And now in my position in the Office of Health Systems as the Health Systems Research Advisor, I've had an opportunity to talk to a lot of people about health systems over the last 4 years. And all these activities have provided me with a perspective on this topic that we're discussing today. But that perspective that I'm going to share with you today is really, it's mine and mine alone. I'm not here representing the views of either the Office of Health Systems or the Global Health Bureau or the Agency for International Development, okay? So I just want to say that we do have one other person from AID. I was hoping there would be more people here because it's quite possible that what I have to say other people might agree with or disagree with. And it would be good if that happened because it would enrich the perspective, which is just one perspective, and also lead for a better discussion. So Estelle and Natalia is here as well. Natalia Romero is in the back of the room, so we'll see. The first thing I want to say, though, is I want to reiterate a really important point in the paper that Grace presented, and that is that both support and strengthening are necessary and important. And both are represented in USAID's engagement with health systems through our mechanisms at headquarters and also through our mechanisms in the field. But when I think about these two approaches and their relative emphasis in the organizational context in which I work, I see a case of a spirit for more strengthening than we're currently doing, but the organizational environment and the rules of the game not necessarily enabling this increased appetite, I think, for moving more and more in the direction of system strengthening. And I'm going to expand on that. I believe that many USAID staff who work in health, both in headquarters and in the field, would acknowledge, at least in theory, that investment in comprehensive strengthening offers the promise of sustaining at scale the short-term gains of the many targeted disease and health promotion programs that USAID supports. And there are many examples of USAID-supported investments in a wide array of health system strengthening activities over the years and all throughout the world. And many of you in the room have contributed your technical expertise in the design and actual implementation of these activities. And some of these examples include social and community-based health insurance, performance-based financing, decentralization, regulation, governance, service integration, essential pharmaceutical management, health workforce development, and quality improvement. And there are others, but I'll just mention those. But all these activities have one thing in common, and that's to improve the performance of the system as a whole, thereby enhancing the functioning of multiple public health programs simultaneously. I think this just echoes the point that Grace made. But despite all these examples that I just cited, I would argue that these kinds of activities, strengthening, remain largely opportunistic, underfunded, and somewhat on the margins of USAID's principal engagement with health systems, which I believe is really more health system support. Support's prominent place, I think, is largely attributable to factors beyond control, interests, or preferences of individual actors in the agency. Rather, a variety of institutional factors